Afternoon, and thank you for staying for the Omic workshop. We're going to go ahead and get started because why not start on time? You're here, we're here. We're scheduled to go until 3:15. Denise will be here helping with questions until about 3:40, and I will be here through tomorrow's meeting, so we'll be happy to answer questions. Just as a reminder, I believe all of this is being recorded. And so if in the Q&A I say I'll talk to you about that privately, that means I'll talk to you about it privately. So first, thank you to Aapos. Omic and Aapos have had a long relationship whereby we provide a risk management program every year. And hopefully you picked up a green sheet as you came in. Whether you're an Omic member or not, please fill this out. It helps us be able to come every year and present. And I'm really pleased this year to be co-presenting with Denise Chambly, who is an Omic director and has worked with me a lot, especially on ROP. I'd also like to thank all of the Aapos members who I've been mentored by, starting with Susan Day, Jim Sprague, Bob Gold, and Denise. It's really been a privilege to work with all of you. So when we were picking a topic for this year, Denise said she'd really like to look at the worst case scenarios. Jim Sprague and I presented maybe 4 years ago a frequency analysis of claims against pediatric ophthalmologists and strabismus specialists. So what were the most common types of lawsuits? And this is the ones that resulted in the highest payments. So what we're going to do is give you a few introductory remarks. Denise will be presenting the 10 cases. And since there was some repetition in terms of a condition, we did the top 10 conditions. And then I will, after each case, present some risk management recommendations or else try and explain the claim process. And can everybody hear me okay? We got this horrible light right in our eyes, so at some point we may have seizures. We have no financial disclosures. I think few pediatric ophthalmologists do. So as I mentioned, please fill out the attendance form. The risk management discount has been increased to 10%. And if you're not an Aapos member, you get a 5% discount. So please make sure you fill that out. So I wanted to start by giving you a sense of where ophthalmology stands overall in terms of lawsuits. So this is what is called a frequency analysis. And the orange is the ones that ended up with a claim, and the other is all claims. But ophthalmology is way down. So first we want you to take comfort in that. Since we're going to be presenting high payment cases, this is more stressful than our usual talks. And so we want to try and put these high payment cases in perspective. So ophthalmology is well below even the all-physician mark, and there are not many specialties below ophthalmology. And then we'll give you a sense of pediatric ophthalmology within ophthalmology. The first thing we want to remind you of is don't panic if you get sued. Statistically, using only Omic data, and we now probably cover about 40% of private practice ophthalmologists, you will have 3 malpractice claims within a 35-year practice. So that's the statistical certainty. We expect in the med mal business for you to have a claim. It doesn't mean it's a meritorious claim, but, and in fact, if you look at these numbers, only about 9% go on to trial, and we'll talk about going to trial versus settling. We win in 80%, 88% rather, if we take it to trial, and less than 1% of closed claims resulted in an adverse jury verdict. So, you know, it's a common thing to be sued. It's an uncommon thing to be found negligent. And sometimes, as we'll talk about in these cases, there are payments, indemnity payments, without negligence. So first, we don't want you to assume that just because there was a payment, there was negligence. We'll be sharing criticisms voiced by the experts. But we're trying to put in perspective what were the largest payments and what can we learn from them. So I'm now going to pass it over to Denise.
So just before I get started, thank you all for being here. Hopefully we can all learn something together today. And thanks also to Ann. Some of you may not know, but Ann has been a huge advocate for pediatric ophthalmologists in the Omic world and in our world. So, you know, we talk at Omic a lot about frequency and severity. Frequency, obviously, is how often we get sued, and you can tell by this diagram that the number of cases that involve children are really, really small, less than about 5 per year. But the severity is huge. And you might note that the scale doesn't go high enough for pediatric ophthalmologists, unfortunately here. So your average general ophthalmology suit settles for around $200,000 or less, whereas with children, it's around $1 million. So we looked at the top 10 payments ever in Omic's history, and you'll see that they range from $3.375 million down to $1 million. And what struck me and why I wanted to do this talk is at Omic I saw this slide and recognized that 7 out of the top 10 involved children. But what we're going to do today is talk about not just the top 10 payments ever from Omic, but the top 10 conditions paying the most that involve children or adult strabismus. So we are being factual here. We're giving you the real cases, but we are the messengers, not the jury. And so some of these cases may make you angry as they do us. Please bear with us on that, and remember that the degree of negligence does not always equal the settlement amount. And just because there is a horrific medical legal outcome doesn't mean that we gave horrific care. So bear with us. So the highest Omic payments have been from retinopathy of prematurity. And as the previous slide indicated, 4 out of the top 10 were due to ROP. And their settlement amounts were between $3.375 million and $1 million. We've talked a lot about ROP, so we're really not going to talk a lot about it today, but I just wanted to briefly go through those 4 cases and let you know what happened. The earliest one of these 4 was in 2003. It was a 27-week-old baby who was seen at 31 weeks, and a 6-week follow-up was ordered, and the outcome was not good. This next one was a really particularly sad and hard one for me, because it was a 23-week-old baby. The doctor was doing everything right. The baby was seen at 29, 31, and 33 weeks at 2-week intervals for minimal ROP. And then he wrote at the 33-week-old visit, he wrote in the chart follow-up in 2 weeks, which was appropriate. The chart itself, his note in the chart said follow-up 2 weeks, and the neonatologist and the nurse practitioners also wrote in their subsequent notes follow-up in 2 weeks. Unfortunately, about 6 weeks had gone by, and they were still saying follow-up in 2 weeks, not realizing that that 2 weeks expired many weeks ago. And so by the time they all realized that the baby needed to be seen, it was an 8-week delay, and the baby was already detached. The reason this happened is because he had a ROP logbook, in which case, in the logbook, he wrote normal. So despite the fact that the real chart said 2 weeks, the logbook did not. The third one was a 26-week-old baby who was seen at 32 weeks, and a 6-month follow-up was ordered. And the last one was a 24-week-old baby seen at 31 and 33 weeks, and a 4-week follow-up was ordered. And it's interesting because we used to see with ROP mostly what I call system issues, where they didn't follow up properly, or appointment in the outpatient appointment was not made from the nursery. And I think you all are all familiar with these. But in these 4 cases, which again have been our more recent ones, 3 of the 4 are not system issues. 3 of the 4 are related to follow-up intervals. Okay.
Oops. How do I go back? Okay. So I'm going to step back a second, because when I looked at the top 10 conditions that resulted in very high payments against pediatric ophthalmologists, 80% of those are diagnostic delays. So most of my comments after each case, I'm going to look at a different aspect of diagnostic delays. So if we look at Omic's entire book of claims, 3 conditions contribute to the vast majority of these cases: retinal detachment, glaucoma, and foreign bodies. The most costly, so again, severity-wise, though, it's the ones we're talking about today. It's the pediatric cases. What are the clinical reasons? Sometimes it's just an inadequate history, and we'll go over this in more details, but a failure to ask for a medical history, a failure to read staff notes. In some of our cases, the staff had put really vital information that they had obtained from the patient or the family in the notes, but they weren't read, and the physician didn't ask, and physicians not reading their own prior entries. And I have enormous sympathy for the pressures you're under in a busy practice, and it is only getting worse. We know that. We know how the reimbursements are going down, and in order to just make ends meet, there has to be a pretty rapid flow of patients through your practice. And so a lot of the recommendations I'm going to make are not going to be very time sensitive. They're not going to be ones that are going to seem really easy to implement in terms of the pressures on you, but this is what we find really is the way to prevent these. So in eye injury cases, one of the most significant findings in a delay in diagnosis is a failure to ask the mechanism of the injury. And then, as Denise mentioned, especially in the cases we're presenting in relation to ROP, is not being familiar with current clinical guidelines. And so one of the things we did with ROP was to put the clinical guidelines, all of the current ones, in one document on our website for anybody to have access to, and ask our doctors to make them part of a written protocol. So at the point of care, the follow-up intervals are there, the diagnostic criteria, the treatment criteria, the screening intervals, everything is right there at the point of care. Other clinical reasons: if you're doing exam on a patient and your diagnosis accounts for what you're seeing, you're going to be less likely to question your own diagnosis. Other problems we've seen is comprehensive exams were not done, especially dilation. We were asked to look at the whole problem of dilating or not, and it was brought up in one of the talks this morning, and we've been asked to develop a pediatric-specific dilation consent form. We don't have time to address that today, but we will be developing that, and we'll post it. System issues are a big problem. And so what we mean by system issues is all of the aspects of care that don't have to do with a physician's knowledge or judgment, with the patient's own disease process or behavior, or clinical knowledge that's known or not known about a disease. So one of the biggest problems, which again is just going to get worse and worse unless you all are put into accountable care organizations and made to talk to one another, is multiple physicians involved in care, and we're going to look at that. So if there is more than one physician, the likelihood of crucial information not being passed on is very high. And also the assumption that the other physician did rule out the worst case scenario or did do an adequate workup. Office scheduling and follow-up protocols are going to have, unfortunately, occasion to bring them up repeatedly, and we have sample protocols on our website, and I'll be referring to those. Reliance upon a patient or family to schedule follow-up protocols. My very first ever talk at Aapos, when I encouraged you to believe that you had follow-up duties, one doctor after another got up and told me that he or she disagreed very strongly with everything I just said. You do have follow-up duties, and you can choose to rely on parents to make those really crucial appointments and talk to me later when the case comes to court, or you can just make those appointments yourself. Tracking and follow-up, we'll talk about what duties are required in that, but this is a huge system problem that, again, the way medicine works is really a challenge for your offices, for time management, for workload for you and your staff, and I do feel badly. As for ROP, all of this is on our website, open access. We have an analysis of all the cases in great detail. We have office and hospital tracking systems. We recommend triple tracking. We also, as I mentioned, have the clinical guidelines at the point of care. And what our latest move is, that's been working much better than just about anything else, is if you're insured by us, with your permission, we write to your hospital and send them certified letters and say, if you would like Dr. Chambly to provide ROP care with malpractice insurance, you must abide by certain safety measures. So they have to have an ROP coordinator. They have to have written protocols with triple tracking, the clinical guidelines and everything. We don't tell them Dr. Chambly can't work for them, but we just say we won't insure her if the hospital doesn't help. And they don't want to insure you, as those of you who have tried to get them to do that now. So it's been extremely effective in really pushing them to do the right thing and to have some skin in the game.
Okay, so our highest payment was ROP, and then the other conditions, I'm just going to present the cases as they appeared to us. This one was a 9-month-old baby who was referred to the pediatric ophthalmologist with a 1-month history of asymmetric nystagmus and a head tilt. He made the diagnosis of spasmus nutans, but did not do any further workup, recommended that the baby come back at age 2, and to call him sooner if there were any changes. The baby did not return until age 4. At that time, there was proptosis, temporal optic nerve pallor of both eyes, and the MRI showed a large optic nerve glioma. And this physician had been in practice for over 30 years and had never been sued before. So obviously, the baby was blind, and the case settled for $2 million.
Just as a quick comment about the amounts of these. If you remember, you probably don't, that big chart, who was at the top? Neurosurgery. And OB-GYN was very close to the top of overall frequency and severity for physicians. This is ophthalmology's equivalent to bad baby cases and not inadequate neurosurgery. So a bilaterally blind baby or even a unilaterally blind baby has tremendous jury appeal. And so a lot of these things are just because of who the plaintiff is. That if you had an adult with blindness, that average Denise talked about with an average settlement of about $200,000. That's the difference between a baby as a plaintiff and an adult. So the cognitive approach, there have been a lot of scientific work on diagnostic delays. So one is to ask yourself, and again, I'm aware of what I'm asking you to do in your busy practice, but say, what else could this be? And one way it was presented that I think is just brilliant is, if I'm wrong, what don't I want this to be? Even pausing and asking yourself that question will force you to develop a differential diagnosis. Time and time again, we have not seen in these cases any differential diagnosis. A diagnosis that, in the physician's mind, accounts for the symptoms and no differential diagnosis. And you have to develop, disclose, and document it. Another way to remember to do this and to help you do it correctly is the WITty approach. Worst case scenario, information needed to rule it in or out, telling the patient and the care team, other physicians involved, and documenting.
All right, so next is a 3-month-old baby who was born with microphthalmos and cataracts, had cataract surgery at 4 months of age, followed by a vitrectomy in the left eye. And EUAs were performed in those first couple of years with normal intraocular pressures. For the first 5 years of the baby's life, things were pretty stable. The baby was examined at regular visits. And in 1995, the baby was now 5 years old, so they were able to get a vision. Vision was 20/80 in each eye, and documented cup-to-disc ratio was 0.2. And then subsequent to that, the vision in the left eye started going down, and an exotropia developed. The child was given glasses and a patch. The vision continued to go down in the left eye. They thought maybe the family was not being compliant with the patch, recommended increasing the compliance. And then 1 month later, the child presented with loss of vision on the left and optic nerve pallor. The pressures at that time were elevated, and the cup-to-disc was still reported at 0.2, and the doctor felt that the optic nerve pallor was due to an ischemic optic neuropathy. He then asked for consultation by a specialist, and the specialist felt that there was significant optic nerve cupping, and this was glaucoma all along. And the left eye was treated medically and surgically, but did not have a good visual outcome, and a couple of years later, the right eye was diagnosed with glaucoma. Unfortunately, there were no intraocular pressure measurements between 1991 and 1998. So after the EUAs stopped in 1991, no further IOP measurements were documented in the chart, and there were no EUAs after 1991. For a period of almost 8 years, there were 4 times when the cup-to-disc ratio was documented, and that was within 46 visits. And in the last 5 years prior to the diagnosis of glaucoma, there was no documentation of the cup-to-disc ratio. So this case settled for $1.8 million.
So to harp on the differential diagnosis, when do you want to stop and say, could something else be going on here? Again, the patient had a condition, the doctor had a treatment plan of patching, and the vision's getting worse. So one is if your diagnosis doesn't account for all the signs or symptoms, the condition is not responding to treatment. And you're in a much better position than I am to determine how much time you give something to respond to treatment. But if you look at that timeline, the same treatment went on for several years as the vision continued to decline. If the course is unexpected, lots of patient visits where you're seeing that the family or a patient, if it's an adult patient, is very anxious, that should be setting off all kinds of alarm bells. And if you don't want to see this patient and your staff don't want to see this patient, you don't feel like you have a lot to offer, you're really discouraged, send the patient for another opinion. What do? You start all over. If you're going to keep the child, start all over. Start reading the entire record with an open mind. And again, just keep saying, what else can be going on here and who else can help me? The good news about referring the child to someone else is your liability ends. So once you've sent the baby to a specialist, and we're going to look at this more closely later, the specialist has the liability, a subspecialist, or even a second doctor. Now, if you're the one to whom the child was referred, you have zero liability for prior care. I've had doctors call and say, I don't want to take cases if the kid is already sick. And you don't have any responsibility for care before you got there. Once you get a baby, you are responsible for everything from that point forward, including completely reviewing those records. Any records you have, if you're starting over again or this is a new patient to you, it is presumed legally that you've read those records and that that knowledge is available to you. So if you haven't read them and something shows up that if you were a paid expert and you really pored over these and would have seen it, you're going to be liable for that. But please consider kids who aren't responding well, patients who you're just not sure what's going on, send for another opinion. You might help the patient and you certainly help yourself.
Okay, well, so far y'all probably aren't too upset with us, but this one might change that. This was a 7-year-old boy who fell down and supposedly hit his face on the driveway. He went to the emergency room that night. The emergency room doctor called the ophthalmologist on call, and the emergency room doctor wrote in his note, corneal abrasion with acute inflammatory response. Unfortunately, the ophthalmologist on call did not make any record of this call, and he has no recollection of the call or what he told the emergency room doctor, but the emergency room doctor said that the ophthalmologist said for the patient to see him in the office the next day. Gave the child some ointment and a patch, and the mom called the ophthalmologist's office the next day and was told that this ophthalmologist did not take public aid patients. The ophthalmology office denied that they got that call, but the phone records showed that there was an 11-minute call that day from the patient's home to the doctor's office. So the child was then seen a couple of days later at the Children's Hospital, was diagnosed with a corneal ulcer. The child was reportedly cantankerous, and so they hospitalized the child since the mother would not be able to give the drops at home. It was a Staph aureus ulcer. It was sensitive to the antibiotics. The ulcer healed well, but there was a stromal opacity, so the best vision was 20/100, which remained stable. This case, the doctor was dismissed, but the corporation settled for $1 million.
I love this picture that Denise puts in. So, telephone care. I've said this for many, many years. It's one of the riskiest things you do. You don't often have records with you. You may be in the middle of a fight with your spouse. You may be relaxing at the pool. You may be in your car. It's just not an ideal situation. In the context of an emergency room consult, the ophthalmologist will be deemed legally to have superior knowledge and greater liability. And that's what's going to happen to you. So what can you do about that? You have to drive the conversation by not just taking what the doctor calls you, but asking specific questions. We developed an after-hours contact log to prompt you to ask certain questions, and you can both ask the questions and document it right there. If you're covering for someone, you can then fax it to that person's office. You can fax it to your own office if you're heading to the Aapos meeting, and they're supposed to come into the office the next day. And again, this is on our website, open access. So this handoff, again, best of intentions. This doctor was leaving town, was on call to the ER the night before leaving town, and didn't think to call his office and say, hey, I took a call from the ER, I'm sending a patient in. He normally did that, he said, but he didn't do it in this case because he was probably trying to pack. So he didn't tell his office to expect the call. He didn't tell the physicians in the office to expect the call. And he didn't fax any record. And as Denise said, he didn't document anything. It's very hard to defend you what your thinking process was, what your decision-making process was, when there's, on the one hand, the emergency room physician who, trust me, is documenting and may not be documenting with your best interest in mind, but is documenting the contact and your advice, and a phone record that shows that 10-minute call, maybe 9 minutes of it on hold, but the plaintiff can really say whatever he or she wants about the content of that, and you have no rebuttal other than what is your normal practice. So front office, we have developed sample telephone screening logs for the front office staff, a sample appointment system, because legally your staff may not make decisions about when a patient should be seen. That's considered practicing medicine. If you have written protocols that you've trained them in and approved of, then they may. So the protocols will tell them what questions to ask and then assign a category to the appointment. That is the full extent of what unlicensed staff may do. You have to consider anybody calling you from the ER to be high risk. Whether they're clinically high risk or not, they are legally high risk for you. And again, this is an easy thing for me to say here. I'm a salaried employee. But you have to separate screening from payment, treatment from payment. And in this case, obviously, when you have a patient who is being told her kid won't be seen, and we didn't give you all the details of this, but the mother misunderstood what the condition was, and when she called, said the kid had pink eye. Well, that reassured the staff. Pink eye could be anything, could be nothing. So, but that wasn't what the child had. And the most problematic part of this case, as you might imagine, besides no documentation to support the office or the physician, was, are you going to take a child who ends up with poor vision and whose mother was refused care to a jury? And the settlement would have been a lot higher. So those are just unwinnable cases. So why was the entity, the practice, allowed to be the one to pay this and not the doctor? Well, first, the on-call physician's care was reviewed, and everyone, including the experts for the plaintiff, agreed that the care was appropriate. The ophthalmologist in the office never examined the child, so no physician-patient relationship that triggers any kind of duties. They did not have written protocols, and all the experts felt that, refusing a patient saying, who was referred from the emergency room, was not adequate protocols. The good news about an entity settlement or a practice settlement is that this is not reportable to the National Practitioner Data Bank, whereas if your name is attached to a case that settles with a payment of any amount that's paid by an entity, whether it's an insurance company or your practice, if there's a written demand and you pay in response to that written demand, it must be reported to the National Practitioner Data Bank. This is a patient safety public health measure so that you can't just keep moving from state to state with being incompetent and no one know about it. But as you can see, some of the times the care isn't negligent, but that is going to follow you. So when we can, when it wasn't physician care, we do settle on behalf of a practice, and then the practice, it doesn't hurt the practice really because it's part of their insurance policy, and certainly it doesn't harm the physician. By the way, if you ever are sued, you do have to, if it's a lawsuit, it's in the public domain, and you must disclose that on your credentialing and reappointment. But have the attorney assigned to defend you prepare a statement about the case. Even the National Practitioner Data Bank reports, we presented the case, if I had presented to you what we reported to the data bank, it's put in the best possible light for the physician. So you want someone to word that for you and to explain why you have that.
Okay. So this case is a 51-year-old male attorney, and not only was he a longtime patient of the ophthalmologist, but they were friends. In fact, the ophthalmologist was the best man in the attorney's wedding. So the attorney, the patient, had a long-standing history of strabismus since he was a child, but recently he had developed worsening diplopia and worse control of his exotropia, and had a history of migraine headaches and some disc disease and a little bit of borderline high blood pressure. So they went ahead and planned for a strabismus surgery. Surgery was booked for June 22nd, and the ophthalmologist did the pre-op H&P about a week before. The ophthalmologist had the patient on Pred-G drops prior to the surgery, preoperatively, and a couple days before the surgery, the patient called the ophthalmologist and said he's feeling a little funny, he had a little nausea, a little weakness, felt just a little sickly, and so he had gone to the internist at the walk-in clinic and was diagnosed with a typical migraine headache, maybe some TMJ. So once the patient returned home from the walk-in clinic, he called his ophthalmologist, and he said that he had been feeling this funny thing. And the ophthalmologist said, well, doesn't really sound like anything too concerning, but I'll just change your drops to Polytrim since you think that your symptoms may be from the drops. So the patient comes to the ASC on the day of the surgery, and the anesthesiologist reviews the H&P, says everything looks pretty good. Blood pressure's a little bit high, but the patient doesn't report any complaints. The patient does not report the phone call. The patient does not report that 2 days ago he has been feeling a little funny. And so he undergoes general anesthesia, and the strabismus surgery is performed without any issue. And postoperatively, he's a little nauseated. His blood pressure was, again, a little bit borderline, but he did okay, and he was stabilized and discharged. On the first post-op day, he came to the ophthalmologist's office, and the ophthalmologist gave a retrobulbar injection, tightened the medial rectus, and unfortunately, 4 hours later, the attorney had a severe stroke. He had a carotid dissection, occluding the right internal carotid artery. Bad went to worse. He had massive edema, massive cerebral edema. He had a supratentorial herniation. He then underwent a craniotomy, and they resected part of the right temporal lobe. He had multiple cranial nerve palsies. He was cortically blind, and it was just a horrible thing. Of course, he required full-time care, went through months of rehab, And then 3 years later, his friend sued him along with the walk-in internist. And the claim from the plaintiff, from the patient attorney, was that the ophthalmologist was below the standard of care because he should have postponed the surgery when the patient had high blood pressure, headaches, and quote-unquote obvious and significant signs of neurovascular problems. So what happens then is that at Omic, the claim gets investigated, and plaintiff and defense experts are sought for their opinions. And then Omic tries to determine whether this is a case that should go to trial and what the outcome of the trial might be, to know whether it's better to settle or to take the case to trial. And when this case was being analyzed, they asked, was there any criticism of the surgery itself? And the answer was no. Was there any criticism of the post-op management? The answer was no. The only criticism that they could find was that possibly the ophthalmologist did not postpone the surgery and did not send the patient on for someone else to determine what his symptoms might have been from. When we looked at the record of the ophthalmologist, his pre-op exam really was unremarkable except for that mildly elevated blood pressure. The phone message where he thought the Pred-G drops were causing him to feel funny, although the ophthalmologist did not document this call. The phone call did take place. And then why did he not document those symptoms in his record when the patient called him with his funny feeling from the drops? Again, the patient did not mention his symptoms on the day of the surgery when he spoke to the anesthesiologist and being cleared. So the experts, of course, the plaintiff's experts said that these signs and symptoms should have been something that were recognized as an ongoing stroke or a stroke, impending stroke, or a stroke in evolution, and that the ophthalmologist deviated from the standard of care. The defense experts said that these signs and symptoms were consistent with his pre-existing history of a migraine headache, and that a carotid artery dissection is extremely rare and difficult to diagnose, and that the defendant complied with the standard of care. So the case did go to trial, and the ophthalmologist was found not negligent, but only 10 of the 13 jurors found this, and they needed 11 for a verdict, so it was called a hung jury or a mistrial. The walk-in internist was found negligent, but also was a hung jury because of a causal connection. So it went to a second trial, and this is the really sad part of this case. This ophthalmologist had been dealing with this again from his who had been the best man in his wing, and the emotional stress just put him over the edge. He had been dealing with this for 7 years, and he ended up acting out in the courtroom and then checked himself into the hospital for a quote-unquote nervous breakdown. And so he was unable to be defended. And interestingly, the internist was found not negligent. So again, he'd been living with this for 7 years. It settled for about $1 million, and the defense costs were about $200,000.
This is a horrible outcome for both the patient and the physician. And there's actually something called the malpractice litigation stress disorder, and it's very real. Omic has guidelines for responding to unanticipated events that go over everything from who to disclose to, who should do the disclosure, when, what to document, what not to share. And part of this is called Heal the Healthcare Team. So let's say something, hopefully never anything this horrible, but let's say you have either a very unhappy patient or a patient who has a severe complication or a poor outcome despite your best care. You really need to talk to your staff who are involved and have a debriefing. So a lot of you are going to worry about well, I thought I wasn't supposed to talk to anybody. How can I really share about this? So I'm going to distinguish between talking about the impact of what's happened and talking about the facts of a case. So in terms of the impact, it will certainly undermine your sense of confidence. You'll start second-guessing yourself. We see many, many physicians develop anxiety, depression, sleep disorders, marital problems, financial difficulty, gambling, all kinds of things just from the stress. And studies also show that while you're under that kind of stress, you're distracted, and so pretty soon you have 3 of these in a row, boom, boom, boom. So it's really important to figure out that, A, it's upsetting to everybody and talk about it. So identify resources and talk to your staff about this. And here's the language you can use. The case my patient had a serious medical emergency after surgery and will not get well. I'm devastated. I had a very difficult time diagnosing my patient, which led to a delay in treatment. I feel really badly. The treatment I ordered made my patient worse. I feel like quitting. And trust me, if it's your staff member who turned that public aid patient away and got you sued, they're going to feel horrible too. So what you cannot share are the specific facts. But let's say you had one of those telephone screening problems with your staff. Are you just going to not talk about telephone screening? No. You're going to say, we're going to have a staff meeting about telephone screening. And I want you to help me figure out any of the worries you've had, any problems you've had, any things that have come up. So you're going to focus on an issue and you're not going to discuss a specific case. That's not only permissible, it's highly advised. And obviously call your risk manager if you need help doing that. We do that, regardless of who your company is. Risk managers will help your staff through that. They'll help you through it. We can do an event analysis. We can do training through webinars specific to the event without ever talking about the facts of it, and it's perfectly fine. As I mentioned, watch for symptoms in yourself and contact your own doctor. So now let's move on to, was there a way to prevent this case? The defense experts on our board, and let's say we have a critical defense expert. We don't stop there. We get one after another, and only if we see that there is no one who can support this care do we give up and say, well, we have to settle. But what they looked at, they said, this was not something that could have been prevented. So I'm not necessarily talking about this specific patient, but hypertension has come up as a problem in many, many, many cases. If you were in oculofacial plastics, trust me, if you saw somebody walking in with 150 over 100, you would be extremely nervous because of hemorrhage, and you certainly would not have discharged that patient at 178 over 100. I mean, I think that that's where maybe there were some problems. But here are some sample guidelines that are from our website that we developed in conjunction with Dr. John Shore, who's the chairman of our board, who's an oculofacial plastic surgeon. This is what he does in his own surgery center. If someone comes in with either a systolic over 200 or a diastolic over 110, there's no discussion. The procedure is canceled, and they refer the patient immediately for a workup. If somebody is between 90 and 109 or 160 to 200, first they give the patient 5 minutes to see if it's the white coat syndrome. But if the pressure is still up, and so they'll certainly postpone, or they'll admit the patient to the hospital. If a patient has come a long way or it's a condition that needs to be treated now, you don't do that patient in your own surgery center. Trust me, you really don't want to do that patient in an outpatient surgery center, but admit the patient to the hospital. So these are available. It's called office-based surgery for adults, but they're good guidelines for a number of things. It also talks about if you do procedures in your office, what kind of emergency equipment, what kind of sedation you should be doing, American Society of Anesthesiology criteria for how risky it is for the patient. So all of that is on our website, as well as a very detailed discussion of hemorrhage associated with ophthalmic procedures. I don't know how many pediatric ophthalmologists or business specialists do blepharoplasty, but a lot of comprehensive physicians do in their offices. And hypertension is one of the biggest risk factors for hemorrhage. So that's a very detailed document that also, if you're wondering what our recommendations are about anticoagulation, whether you should stop it, continue it, what are the various things to be said about that. It's in that document, hemorrhage associated with ophthalmic surgery. Finally, Tamara Fountain, who is the chair of our risk management committee and another oculofacial plastic surgeon, has developed a consent form related to anticoagulants. It's just a little addendum you could have a patient sign. Many patients are on this. They're on either vitamin E, they're on aspirin, they're on NSAIDs, they're on Plavix. So as soon as I do my part and put it into the right order, it will be up on our website again, open access.
Okay, this case was very complicated and involved a 16-year-old boy who fractured his orbit. The bottom line, and there's really not much instructive about this case, so for that reason and for time reasons, we're going to skip it. But essentially what happened is he had a thrombus in his orbit, and that damaged his optic nerve and caused him to lose vision, and that case settled for $500,000. The next one is a 3-year-old boy who was playing with a glass bottle. The bottle broke and injured his eye. He was taken to the emergency room and was in a small town. The ophthalmologist on call came in, saw the patient, and diagnosed the corneal laceration. They did not have an anesthesiologist at this small hospital. They did have a CRNA, but the ophthalmologist felt that it was better that anesthesia on this 3-year-old not be done in this hospital, and referred the family to a cornea specialist in another city for his surgery. He put a Fox shield over the eye. He asked the ER doctor to give the patient some pain medicine. The ER doctor gave them a prescription for Tylenol with codeine, or gave him some Tylenol with codeine, observed him for about 45 minutes, and put him in the car and sent him to the next town. Unfortunately, the child vomited during the drive, and by the time they got to the next ER, the cornea specialist found that the child had had an expulsive choroidal hemorrhage. Unfortunately, the ophthalmologist at the original emergency room did not document anything. He did not document the extent of the corneal laceration. He didn't document any vision, nothing, no note was written at all, and so this case settled for $450,000.
So everybody's favorite acronym, EMTALA. This is the second. 2 of the top 10 conditions had to do with emergency treatment. And I imagine many of you are still forced to provide on-call coverage to hospitals. I know very few physicians who are happy about this. So what I wanted to talk to you about is what are the federal laws governing this that actually in this case may have helped the physician if he had been aware of them and followed them. So there are conditions that have to be met before you may transfer a patient from one emergency room to another. So first, you can only transfer to a higher level of care. And the review of this case, by the way, they felt that was completely appropriate. There were concerns about anesthesia safety and about the amount of work needed to be done on the eye, and that a corneal subspecialist was appropriate. Here was a physician who was trying to expedite the process. In this area, it would have taken about 2 or 3 times the amount of time to get the baby transferred by ambulance. And so everybody agreed it was a good idea to let the parents take the child in the car, trying to do the right thing and get the baby, the 3-year-old, care sooner. So what happened is that the breakdown in the care is that there are specific laws about stabilization before you transfer and how you transfer. And again, retrospectively, you look at these cases and you think, you know, what were they thinking? But in the middle of it, you know, a kid with a pretty bad injury and trying to get the right care and being a nice person, you know, can get you in a lot of trouble. So the EMTALA transfer rules, by the way, another one of those open access documents, 2 documents on EMTALA in our risk management recommendations. One is an overview that's pertinent to you. I'm not going to go, I didn't go a lot in this document into pregnant women, things like that. So it's EMTALA for ophthalmologists, and then the second document is just about on-call ophthalmology. What are the rules? Who's responsible for follow-up? When do I have to follow up? Do I have to follow up? So all of that is on the website. So this is from the rules. So to transfer a patient from one emergency room to another, you must meet these 4 conditions or you may not legally transfer. The first is before transfer, you have to minimize the risk within your capacity and capability. So if there are on-call physicians, anyone you have to bring in, you must bring in and minimize the risk for this patient. Here is what wasn't done right before is to reassess the stability just before the transfer. And again, they didn't talk to one another. The emergency room physician said that he told the ophthalmologist he was going to give codeine. The ophthalmologist had no recall of the conversation and didn't write anything down and said, plus, that's the emergency room physician. I would rely upon that person. But what did I say earlier about that emergency room case? Who is held more liable? Who's held to the higher standard of care? The subspecialist. So remember that if you're on call, you're the target, and you have to be really sure about what you're doing and talk to the ER physician and clarify who's doing what. And we actually, in a couple of these cases where we knew we had the potential of very high settlements, we did jury research where actually it's pretty sophisticated. Lay people volunteer to be on an internet jury. Your social media folks would love this. And we had a couple of juries, and they all felt that the eye physician had the superior knowledge and greater liability. They opine on a lot of the facts of the case. One of our last cases, it was significant in the issues we focused on in the trial. They also assign proportions of blame and give us a sense of what a jury would ask for or would give as a verdict. So the first rule, stabilize before. Second, you have to find a hospital that will accept this patient. Those of you who feel like you're being dumped because you're getting these transfers, you do not have a choice. If you are an on-call ophthalmologist and your ER calls and says, Hospital A is sending us a patient, and you think they're sending you that patient because your colleagues in ophthalmology at that other hospital refuse to take call anymore, and you don't want to see the patient, you're in very serious legal trouble. You may not refuse. If you are a higher level of care and you have the capacity and capability, you may not refuse. Do not have that discussion then. Later follow up with certified letters to the chief of the emergency department of ophthalmology at that hospital and have area discussions. But if someone calls and says a baby's coming or a kid's coming or whatever and you're on call, your answer is, when do you want me to be there? The hospital is required to transfer all records available at the time of the transfer, including an informed consent signed document. So the patient has to sign a document following a discussion with a physician who certifies that the benefits of the transfer are greater than the risks. That didn't happen here. There was no discussion of the risks of the transfer, including the transfer itself. So that didn't happen, and neither physician had that discussion with the parents in terms of what could possibly happen during the transfer that might be a problem. Notice the last bullet point. By law, the hospital sending the patient must put the name of any on-call physician who did not respond in the transfer agreements and must also report that to CMS. The fourth thing, which would have probably prevented this problem, is, first of all, I forget the year of this case, but it's one of those cases that helped the government clarify these transfer rules, because EMTALA is an evolving doctrine of law. But you must. It's not think about using qualified personnel, equipment, and transportation. It will almost never be acceptable for a patient to self-transport if the patient is still deemed to have legally an emergency medical condition. Now, if the ER physician and you agree that the patient is stable for discharge and can come to your office, EMTALA no longer applies. And then the parents can take the child. You can have the patients, adult patients, come over. But if the patient is deemed to still have an emergency medical condition, then you cannot allow patients to transport themselves. Again, this was an impulse out of kindness and out of concern, but obviously, retrospectively, these parents are not qualified to monitor a child en route to another hospital, and there was no equipment.
Okay, so this one is a 20-month-old baby that was referred from the pediatrician for strabismus to a general ophthalmologist. The ophthalmologist saw a poor red reflex and thought that the child might have PHPV or toxicara and sent the baby to a retina specialist to rule out a tumor. A B scan was done, showed a thick posterior retina and a serous detachment. The retina specialist diagnosed a retinal detachment with Coates disease. Performed an EUA 3 weeks later to confirm Coates disease and did a vitrectomy with cryo and a buccal. The patient seemed to be stable. He did multiple EUAs after that and felt that things were pretty stable until so this is about 4 months later, and the retina still looked good, but the patient had developed glaucoma with a hyphema and iris neovascularization. He recommended another vitrectomy and lensectomy. A month later, the family noticed this gray spot on the eye, and the eye was red and irritated. And I believe the retina specialist wasn't available at that time, and that's why they went back to the general ophthalmologist. And the general ophthalmologist thought, well, he's had some surgery before. I think that gray spot is just some post-op changes. So we're now at about a year, a little over a year out. He does the lensectomy and vitrectomy, the retina specialist does. And then a few months later, they noticed the eye is protruding and swollen. Again, the retina specialist wasn't available. The retina specialist had noticed this cyst on the conj and had scheduled to remove that, but the surgery was canceled because the patient had been ill. So again, the family goes back to the original ophthalmologist to evaluate this protruding swollen eye. And the ophthalmologist finds a corneal ulcer, lid swelling, chemosis, thinks maybe there's endophthalmitis, maybe it's orbital cellulitis. So he himself, the general ophthalmologist, does an EUA. He aspirates vitreous for culture and antibiotics since he thinks it might be endophthalmitis, does a CT scan which shows calcification in his globe, and isn't sure whether this is infection or inflammation. So remember, the baby was already scheduled to have a conjunctival biopsy by the retina specialist, who then a month later does this conjunctival biopsy and finds retinoblastoma. The baby had an enucleation and underwent chemotherapy and unfortunately passed away about a couple of years later. So the lawsuit was against both the general ophthalmologist and the retina specialist, but the general ophthalmologist was dismissed and the retina specialist settled for $425,000. A good time to remember our healthy, beautiful children.
Anybody else as depressed as me? This is like one of the worst talks. So some questions that came up in the evaluation of this case. 2 doctors sued, and actually the comprehensive ophthalmologist had seen this child many, many times. So there were 2 doctors involved over a long period of time, and the question came up, whose patient is it? And if you're the comprehensive ophthalmologist, do you have a duty to question the diagnosis of the retina specialist or any other kind of specialist? So that's what I'm going to talk about. So as of the initial visit, this comprehensive ophthalmologist, and you may wonder, why weren't they sending this kid to a pediatric ophthalmologist? This is actually somebody who ended up in cornea. But no pediatric ophthalmologist ever saw this kid. But the comprehensive ophthalmologist felt right away, I'm out of my depth, retina. So from that time on, he felt that with a retina diagnosis, which he certainly wasn't going to try and manage coats, and he couldn't do any of the procedures, that he was just kind of available as part of the team, but that the retina physician was in charge. The plaintiff experts had a lot of criticisms about this, but the defense felt and was able to convince the plaintiff attorney representing the family that it was reasonable for this physician to rely on somebody who's a subspecialist and he didn't have a duty to question this other doctor's care, and that he had met the standard of care. And so we were able to get the comprehensive physician dismissed from the case, and the case proceeded against the retina specialist. Now, the retina specialist, all the experts said it's very difficult to distinguish those two, which means you have to rule out the fatal disease. You must, from the beginning, rule out the fatal disease, and that was never done. Remember the initial referral, poor red reflex rule out tumor? The comprehensive ophthalmologist thought of it from the beginning, but deferred to the retina specialist. So again, if you were referring someone who is a subspecialist, a different specialty to you, you certainly may rely upon that specialist, but if you have concerns, there's nothing to prevent you from raising those. And especially to follow up on your initial referral and say, by the way, I saw you said this baby has coats. Did you rule out the tumor? That's, or even for your own education. Oh, I thought it was a tumor. How did you rule out that it wasn't a tumor? And maybe that would have gotten the retina specialist to do something differently, or maybe not. He may have just said, who do you think you are? I'm the retina specialist. You can't challenge me. But it's at least, I think, comforting to know that you are not responsible for somebody who's supposed to have superior knowledge to you.
So this is a 2-year-old who had a history of craniosynostosis, and the pediatric ophthalmologist looked at the optic nerves and thought they looked abnormal, made the diagnosis of optic nerve drusen, and recommended that the patient come back in a year. When the patient returned in a year, he felt that the optic nerves now looked pale, and he was concerned. And he felt that the patient should have a CT scan. But the mom said, well, we've already had a CT scan. We really don't need to go for that again. And the ophthalmologist said, well, if you're not going to get a scan, then I definitely need you to go to an academic institution and have another opinion. The family never went to the academic institution and returned a year later and now had lost vision in the right eye. And the academic institution then became involved and found that this was a case of pseudotumor cerebri, and this case settled for $425,000.
So the dreaded topic of follow-up duties, and this is where I really want to say I'm the messenger. This is case law. There's no law in your state that will say exactly what your follow-up duties are, and even in EMTALA, follow-up is very vague. It's actually the hospital that is given follow-up duties, not the on-call ophthalmologist. However, check your medical staff bylaws. Some of them do state that you have the duty to follow up on patients who are seen in the emergency room, so you want to know that. But so when does a follow-up duty begin, and how far do you have to go? Those are the questions I'm always asked. So it begins with a relationship, and as we've talked many times at this meeting, a relationship begins way before you think it does. Once your office has had a discussion and exchanged patient-specific information, juries have repeatedly found that that starts the clock ticking in terms of a physician-patient relationship. So you have a relationship, you then just know that you have follow-up duties after every visit. So we're going to talk about how to make this the least painful possible. So each time you see somebody, you have to determine the follow-up interval, you have to communicate it. Now, a suggestion is to schedule the appointment before the patient or the parent leaves the office. Doesn't matter if they say, I don't have my appointment book or I'm not sure. You want them on your books so that you know when they don't come back. If a patient, we used to say follow up on missed appointments. One of our ROP cases that after taking it to the state Supreme Court, we won, but it had originally been a $1.5 million settlement. That practice first didn't screen to ask if the babies had been seen for ROP in the hospital, and that would have only helped one of the two kids because the other kid had never been seen. The doctor had seen a different baby, different name. The mother had changed the names. I mean, everything that could have gone wrong, but that was the case that got me working on ROP. But in that office, as long as the appointment was rescheduled, and maybe that's the protocol in your office, you may feel like, oh, I'm okay. We have seen quite a number of ROP cases be rescheduled into blindness. So certain patients, it's never okay to reschedule. Some patients, it doesn't matter at all. So you need to do some risk stratification. I think it's easier to just follow up on everybody. So my recommendation, and again, this is on our website, one phone call. So first, this patient didn't come. You've lost money. Do you really want your staff making 3 phone calls and 3 letters? No. It's more wasted staff time and money. You make one call, and if I don't reach Mrs. Chambly, actually she's not a Mrs. Chambly, but if I don't reach this patient and have her agree to do what the doctor wants her to do, there's no more phone call. You go directly to a letter. We have sample letters on our website. 99% of the cases, one missed appointment letter is all you ever have to do. Make it specific to the condition. As you know, we've been following Johnny for amblyopia. You missed your appointment. If you don't get the treatment you need, Johnny's amblyopia may get worse. Call us as soon as possible. Now, if there's a treatment window, if you need, if that patient has something that needs to be done promptly, put the treatment window in or the phone call window. But for 99% of your cases, your patients, that's all you ever have to do. Juries want to know that you noticed that the patient didn't come and that you took some action. So, and with children, your duty is to the child. And it's not the child's fault that he or she has spacey parents. And what we have learned to our peril in the med-mal industry, and what you all need to really understand, is that you cannot rely upon parents. So if you send somebody out for a test or an appointment with another physician, you need to be tracking that. So this doctor suggested that this patient go either for another scan or to an academic institution, and relied upon the mother. And actually, the first case, too, there was a delay in follow-up. So ideally, it's easier in the long run to have your staff schedule that than to go through a 7-year lawsuit or to have a kid end up really sick. And, again, to get this patient on your book so you notice if there's something wrong, schedule a follow-up visit. If you know it usually takes a month to get a report back, schedule a visit for a month, and have your staff check to make sure before the parents come back that you've gotten that report. And if not, you start calling. Did you go for the test? No, why not? So here's my other great slogan. Patients are ignorant until proven educated. You have way more knowledge than they do, and they will try everything they can to look like they don't know anything. We've had medical personnel claim that they didn't know anything about the risks of things, so lay people are really going to emphasize that. So you have to tell them what's needed, why it's needed, what would happen if they don't get it, and then in very few cases, you may have to report the child to Child Protective Services for potential neglect. In our ROP package now, we have those sample letters ready, where from the first time you're told if you don't bring your child for follow-up, we may call Child Protective Services. It's our duty. We're not trying to get you in trouble, but we're really worried about your child.
Before I start this last case, I just want to digress for just a second to say that even though we're presenting the worst, most severe cases here, with pediatrics in general and with all of the other cases that come to Omic, the culprits seem to be the same thing: follow-up, differential diagnosis, and documentation. Would you say? So those are the big 3 things, no matter who is the specialist, no matter what the case is. And so I think if we all keep that in mind, not that we'll ever be able to be perfect, but that hopefully we can keep ourselves out of trouble. So this last case is a 7-day-old infant. The family physician saw the baby, said that the baby's lid had been swollen for 1 day prior to presentation to the family physician. There was a little bit of a temperature, rectally 100. The baby had vomited once, and the family physician asked the pediatric ophthalmologist to see the patient that day. The doctor felt that it looked like a little insect bite. There was no proptosis, no chemosis. Really, there was nothing except for this little thing on the lid. He gave some Axitrol ointment, cold compresses, and said, come back tomorrow. Let's take a look and see how you're doing. The baby came back the next day. The lid swelling was really minimal at this time, but there was some swelling of the cheek. And the ophthalmologist said, you know, things are looking a lot better, but just call your pediatrician if anything gets worse or you have any other concerns. So 3 days from the original presentation, the baby ends up in the emergency room, has pneumococcal meningitis and just a terrible brain damage, encephalopathy, and a spastic quadriplegia.
This is a case I really don't see any way to prevent. And so I'm just going to talk about the investigation process and sort of the perspectives of both sides. So from the parents' perspective and the attorney they hire, I mean, the baby was only a week old, but seemed fine, saw 2 doctors and 3 visits, and then ends up severely damaged. So you can understand why they would think that somebody should have figured out what was going on with this baby. And mainly that the doctor should have missed something. So in this one, as the other ones, we got mock juries and asked them a lot. And so neither doctor took a temperature. And the jurors really focused on this and focused on the fact that no culture was taken. Now, if you see a swollen lid and what looks like a bite and a kid that otherwise looks okay, how many of you are going to take a temperature? But that's what the jurors really focused on, was nobody took a temperature. The mother reported that the baby had a rectal temperature of 100. That's not arguably even a temperature. But they had to find something. I mean, juries don't like these cases. Nobody likes these cases because we all want to feel like if somebody had done something, this kid would have been okay. And I honestly don't see what could have been done differently here. But this is what the jury focused on. The story behind it all, too, is parents with, this makes me want to cry. A week-old baby, and they were told if the baby gets worse, call me or call the pediatrician. Well, it turned out that the eye and then the cheek got completely better. And then the baby started getting very irritable, stopped breathing a couple of times, had a temperature, and they didn't call anybody. And then in the middle of the night, they just realized how sick their baby was. So obviously, you're dealing with tremendous parental guilt here, if they're capable of even accessing that. From the defense position, both the family physicians, experts, and our experts said there was no need to take a temperature or culture that eye. The eye condition improved. By the time the baby went to the ER, the records are very clear there was no eye problem, there was no cheek problem. The child had developed separately an ear infection that was first seen, because it was looked for by the family practitioner, at the ER visit, and the experts felt that the meningitis came from that. I mean, this is really colossal bad luck for this baby. We took this case to mediation after going through a couple of mock jury trials. Mediation in most states is required. It's rarely mandatory. This is separate from a type of way you can choose to go through. May you never go through any of this. But in some places, doctors ask their patients to sign mandatory arbitration agreements. But mediation is a court-ordered process in every lawsuit. During this, as we're preparing to go to trial, because we felt the doctor couldn't have done anything any better, he learned that his co-defendant settled out and was telling the attorneys that, again, I think the eye doctor had more responsibility here. And the doctor, who had been very adamant about defending his care, and rightly so, just felt like, I don't want to be the only person in front of a jury with this kind of an outcome, so chose to settle. So the website has consent forms, recommendations, hotline. We wanted to give you, with all of those filled in, of Omic's top 10. So we are officially out of time, but we are happy to take as many questions together until Denise, and if you could please go to the microphone so that we can hear you. So Denise will be here until 3:40, and I'll be here until the party tonight. And if you need to leave, please feel free. Thank you for staying, and thank you for coming to this. And do please turn in a green sheet whether you're an Omic insured or not so that we can keep coming back.
Mohammed Jafar, Washington, D.C. I think you said it, but can you reiterate it? You are saying that for every patient who does not show up, irregarding of the diagnosis or the complaint when they make the appointment, we should call and send a letter if they do not show up.
So, and I'm assuming you can all hear since we're using the microphone. So, my job is to prevent patient harm and lawsuits. So, yes, I am saying that. Now, if you call me and say, I don't have the resources to do that, what I would do is we would have a long discussion with you and your practice manager about all the kinds of people you see, and we would pick who's high risk, and you would do follow-up just on them. But I think sometimes it takes more energy to figure those out, and it's an absolutely perfect defense that you can prove you made a call and one letter, and like I said, you have form letters per condition, so that is my recommendation. But if you can't do that, work with your risk manager to see who absolutely do you want to be following up on. I'm sorry, so maybe come to this one and I'll repeat that question. Does it have to be certified letters? So the whole thing about certified letters is there is no law we are aware of that in any instance requires you to send a certified letter to a patient for any reason. We're not aware of any law. It's a suggestion that attorneys came up with, and the reason was they felt better, that you'd have a piece of paper returned. And what's the problem with certified mail? Have you ever tried to get your own certified mail? Nobody's home, or the patient won't sign for it. So our recommendation is send it through the regular mail, even if you are going to send it by certified mail. But legally, if you send a letter to the correct address, it's legally presumed delivered. So, again, you're already losing money. I'd rather just see a regular mail go out, and I think you're going to be in very good shape if you ever get sued. We'll just alternate spots.
Malcolm Mazo, Houston. And many years ago, you said that if you refer a patient to another doctor and that doctor never sees the patient, but the doctor has had the referral made to him, that doctor is responsible. By the same token, if you send it and they never go, you as the referring doctor still are responsible. Would you like to discuss that?
No, but I will. This is one of those situations where I'm going to give you my risk management recommendation because I want to keep you out of court, but you're not going to like my answer. So looking at it from a juror's perspective, you send a baby to somebody to get help on the diagnosis, and if you didn't schedule that appointment I recommended to discuss the results, you didn't bother to see if the results came back, then you will be held liable. Maybe we'll be able to get you out of the case, or maybe we'll argue that the other doctor has more responsibility, but I don't want you ever to be there. So I developed these tracking systems that are extremely low tech. I don't have one of those fancy phones. It's on our website. It's a tracking system for referrals and tests. You want to track any kid you're sending out for a test or a referral and make sure you get the results back. Make sure you've scheduled an appointment to see that patient after the results should be back. And if you don't have results, your staff is calling and you're documenting what you found out. If the families change their mind, they don't think the kid needs this or that anymore, you have a duty to obtain informed refusal and explain what could possibly happen. So I just think it's in the long term, for your own patient safety and your liability exposure and your peace of mind, I do recommend following up. It's not going to help you to point the finger to the doctor you referred the patient to if they didn't do it. Now, if the patient is referred to you, this is even harder. So, this is where you might want to, again, risk stratify. So here's where I'll give you a little wiggle room when people have shouted me down on this. If the patient is referred by another physician and the patient doesn't come to you, I would contact the referring physician and document it. That simple thing. I'm not saying you have to contact the patient. It's a good idea, but I would at least contact the referring physician and say, hey, Denise, that kid you sent for the exam never showed up. and then make Denise do the hard work. If it's a self-refer patient, I will cede to your desire not to do anything because you didn't know the patient was coming. You don't know anything about this person other than they scheduled an appointment. I'm risk averse. I would still send a letter, but that's me. Whoops, our person over there gave up. So.
I'm Ajay Soni from Baltimore. I had a question about the case number 4, the one with the phone call from the ER. So you said the jury's verdict was since the doctor had talked to the ER doctor but had never examined the patient, there was no patient-doctor relationship. Did I mishear that?
Sorry, yes. Okay, when do you have a relationship legally with an ER patient? Here's what is absolutely true. If you spoke to an ER physician, had any medical role whatsoever in the care, you have absolutely established a physician-patient relationship with follow-up duties. If your name is simply on the list, but you were never called, under EMTALA, you have no relationship. If, however, your medical staff bylaws say that any patient seen in the ER who has your name on their piece of paper and is sent to you for a follow-up, you want to know about that. So if you've never talked to the ER physician and you were just on call, I don't think you have to do anything. We can get you out of those cases. If a piece of paper shows up at your office that says, I've sent Denise to you and she had X and Denise never comes, I would let the ER doctor know, and I'd try and do a minimal follow-up, send the letter saying, you were seen in the emergency room physician diagnosed you with an eye condition and felt you needed follow-up. If you don't get treatment for this eye condition, notice I haven't said what it is because I've never seen you, I don't know, your eye could get worse, you could lose vision. Again, I think it's worth just having your ER patient never showed up letter, regular mail, whatever the current stamp rate is, and you're done. You don't start a chart. You keep a folder for those for 10 years, and then you sleep better. That's my advice.
And we've had several of those. And there have been several of those cases where the emergency room doctor contacted the ophthalmologist. The ophthalmologist said, come to the office the next day. Either the patient didn't come for several days and wasn't contacted, or the patient didn't show up, and it has not turned out well for the ophthalmologist.
And I'll just say one more thing about the ER. If they're doing you wrong, and they are, write a letter every single time to the head of the emergency room and just explain what your issue is, and keep all those letters. You don't want them sending you information about every person who walked in that they looked at their eyes. But if they expect you to see that patient in it as an outpatient and they send you that form, I think it's really worth your while to do that minimum follow-up. But if it just says we saw Ann, she had an eye condition, and nothing about following up with you, I would do nothing. I forget where we are. I think we're over there. Sorry.
Denise, I couldn't hear what you said about something that wasn't good for the ophthalmologist. What was that remark?
Just now, in answer to that we've had several cases where the emergency room contacted the ophthalmologist. The patient was supposed to be seen in the ophthalmologist's office the next day. Either the patient didn't show up to the office or had a delay in the amount of time that they showed up, and it did not turn out well for the ophthalmologist.
Well, my question, thank you for that. My question is that in one of the earlier meetings here, the no-show rate is about 10%. It's huge. And this last week, was caught up, and just for grins, I went over and said, I'm going to see if this patient hadn't showed before. They hadn't showed up for any of the previous 4 visits. They had a total of 12 and showed up for 5 of the 12. We got a problem, and we're going to address it, but I just wonder, there's just a couple of issues here. One is we don't need these patients in our practice, number one. Number two, maybe that's number two. Number one is this baby needs care somehow, or they wouldn't be making an appointment. Do you have protocols that can help us with this larger thing about most of the people are just going to be people that got complicated lives and no transportation, and mama doesn't work, blah, 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 the usual Medicaid syndrome, family syndrome. But I can see, I'm real glad I came today because I can see that this could really come back to bite us.
I'll let Ann speak first, and then I'll speak.
I would have a very low tolerance for that type of patient. And, one missed appointment, you send the letter. If they miss another one, you explain that they get one more chance, or even after the first one. Just say, everybody has busy lives. You missed an appointment. We're going to reschedule you. But if you miss another one, we may discharge your child from our practice. You may discharge a patient for any reason unless it's a discriminatory one, meaning you don't want to see deaf patients because you don't want to pay for interpreters. Other than that, you don't even have to give a reason. I say get rid of those patients. It's unfair to the child, but you are definitely going to be on the hook for that. So I think that you notice it early, and if there's a pattern, you educate, and you just don't give them a lot of opportunities. Now, what if you're the only pediatric ophthalmologist in town? Again, I'd give them a couple of warnings, and case law is on your side that if patients disrupt the practice by not coming, you're losing income and everything. I think you're within your rights to just say, then you have to travel that 3 hours to see someone else. So call your risk manager for advice, but my advice is terminate those relationships as early as possible. Sometimes that's the wake-up call the parent needs, and they'll do better with your colleague. Sometimes not. Or one other thing to think about is consider Child Protective Services. If this would fall into neglect, then, and it could harm the child not getting treatment, and arguably any of this could. So you might want to give that one shot, but boy, talk about a lot of time. But you may discharge these patients, and I think you should.
Well, first of all, I'd like to say that if anybody has a solution to the no-show problem that faces all of us, I'd like to know about it because I've been working on it, tried everything, it seems, for the last 20 years and don't seem to have an answer to it. But I did not know that Ann was going to give that response, and I just analyzed a month's worth of no-shows and found that over 50% of those were established patients, and over 50% of those had had multiple no-shows, like you said, Everett. And so I have just instituted exactly what Ann said, and I have on when they first come in and say, Dr. Chambly's no-show policy is such, and then they will be forewarned, and one no-show, and after that.
To California. Just what do you think of this approach? The patient doesn't show for their appointment, and then that same day you call them up, either you get a hold of them, you leave them a message, and you offer them another appointment, tell them they missed their appointment, and then you have your staff put a little note on the chart that they missed their appointment, they were called, either they spoke to the patient or a message was left at their phone number. It's not a letter, but it's something that's so easy to do, for our overburdened staffs. Is that legally adequate, even though it might be preferable to send out all these letters?
The problem with a phone call is that you don't know if they ever heard the message. And under HIPAA, unless you've gotten permission from them to leave disease-specific information, you can't give a warning. So I don't think, that's why I say one phone call. It's useless to call more than once, because the only way you can protect yourself is to educate them about the consequences and to prove that you did that. Because you have no proof about the content of the call, but the letter, and again, that's why I have sample letters for the conditions you treat, and we have sample letters on our website, missed appointment, non-compliant. So no, I don't think it's worth another phone call. I think you do have to send the letter, but that's why I don't think you send it certified. You just send it in the regular mail.
So the phone call by itself, even if it's documented by the staff that they called that day, it's insufficient. You have to have the letter also. Even if you have something in writing from your staff, but you're saying that's inadequate. Is that correct?
Unfortunately, you haven't met that burden of educating the patient about the consequences. You don't have proof that you put it in black and white, what will happen if you don't get the care. Now, I'm speaking as a risk manager. You may end up with a brilliant defense attorney and a lousy plaintiff attorney. I don't want you to take that chance in court. So what we know, and that's why we recommend it, is that the one call, one letter, 99% of the time is all you'll ever have to do. And by the way, if you're one of these perpetually kind, tolerant people, unlike Denise and me, and you want to see that patient through 25 no-shows, 6 years of not paying, you may continue to do that as long as you've notified them of the consequences. Or you can never do anything again and just leave them on as never having returned. So, I mean, I know these aren't answers that you like, but my goal is to protect you. I don't want a plaintiff attorney to look at this record and see a loophole. If the record shows a phone call and a letter, they're not going to take the case. They just won't take the case because they're not going to be able to win it unless they find something else. And I know all the rest of your care is perfect.
So I guess the thing to do is have your staff have at their desk a pile of these form letters, put in the name, put in the address, stick in the envelope, and mail it right.
You must sign it. It should not come from your staff. You should sign them. They should tell you. So just bring them to you, have your signature, because if you don't know what the condition is, they may be making the wrong choice about the type of letter or the consequences. I'm sorry, that's a medical decision, and I would feel a lot better. Now, if you're not willing to do that, like I said, plenty of people, even those I really admire, ignore my advice all the time. So if you're not willing to do that, it's still better that a letter went out from your staff. It would be best if it came from you. But if that's what you're willing to do, hey, that's great. But it's best if it comes from you.
It has to be individually signed. It can't be like
Yes, that's my recommendation. Feel free to not follow it, but yes, that's my recommendation.
Jim Knupp from Springfield, Illinois. I wanted a clarification on the Emterra law. When we're on call for the two hospitals in my hometown, despite our Department of Ophthalmology's recommendation in both hospitals that the information not be given to other people, routinely other hospitals are calling and asking who is on call and then call the doctor on call directly and start asking, what should we do about blank? And it has been kind of standard of policy, at least in our area, that we not return those phone calls, actually, among the vast majority of physicians. And in fact, I'll tell you that's what I've done in the past as well. I have told people, I'm not on call for your hospital. I'm sorry, you're going to have to talk to the emergency room doctor, and if they want me to respond, then I will, but I'm not on call for you. Now, will you clarify, I don't think that's what you're saying I should do, but can you clarify for me what I should be doing?
Actually, you're absolutely right that you have no duty to speak to anyone if you're not on call for their hospital. But what you want to do is you want the hospital to back you up on this. So you want to meet with and have it as a written protocol that all calls have to come to the ER doctor, all transfers to the ER doctor. So in that on-call document that I mentioned before, it's some suggested language, and you just say, I am not on call to your hospital, I'm not available to help you, period. So
I should say that to the person who's calling me.
Yes.
So I do have to respond to them and say that.
I think there, if you have someone else you can impose that duty on, a staff member, and say, we got a call from you, Dr. Chambly is not on call for your hospital, we are not able to help you, period. You don't have to go any further. You have zero duty to answer any of those calls. You may answer them. You have the same liability as you would for any other patient. It's, usually the ER is a delay in diagnosis or treatment, but you have absolutely no legal duty. Unless, again, you want this to be clear in your hospital protocols, that all referrals from outside come through the ER, so that if the ER physician calls you and says, Denise, we are going to be accepting a call from such and such a place, I want you to talk to this doctor, then you do it. But absent something like that, you have no duty.
So if the hospital accepts the call from them,
then you're on the hook.
Then we're on the hook.
Yes. And that's why you want to be clear that they're the ones accepting the patient, because there have been problems when a specialist, the on-call specialist, not necessarily the ophthalmologist, tried to accept a transfer, and the ER was absolutely jam-packed, and they couldn't take the patient when the patient arrived. And that's why it's safer for someone other than you as the on-call physician to be handling all those requests for sending people in. Now, I've also seen, and this is, I think, one of the most unfair things, where there are hospital systems where they own 25 hospitals in 13 states, and they put in your medical staff bylaws that you must take all those calls. That would be, so EMTALA is the general law for everyone, but anything in your medical staff bylaws that addresses emergency care becomes part of EMTALA for you. So you want to make sure you know what your medical staff bylaws say. So if they say you have to answer, then you have to answer. Absent that, you have no duty, but you want to go home and make clear who takes those calls and transfers, and it should not be you, because you're not in a position to know what the ER can handle. Can the patient be admitted? But again, if your ER doctor says, I want you to come in, or I want you to talk to this person, then you do it. Does that help?
If someone besides the emergency room of my hospital calls me, some nurse practitioner who's basically receiving these calls, is the same thing.
Right. So some hospitals do have nurses in charge of that transfer process, and if that's a designated person, treat that person as the emergency room physician, and yes, take that call. Because there have been EMTALA cases, not against ophthalmologists, but where the physicians who refused the hospital process got into trouble. So you want to know what the process is and follow it.
Thank you.
Andrew Black from Baton Rouge, Louisiana. In terms of on-call documentation, I like the Omic notebook that has the questions that prompts you to ask the ER or whoever you're talking to some nice questions. But a lot of times, I don't have that, but I do always have my cell phone. And is it acceptable documentation to make notes, like in the note program from the iPhone? And if that's okay, I have a suggestion, too, that I think would be helpful or useful for me and probably for a lot of other people, is that Omic maybe develop like an iPhone app that you can use for on-call documentation. And is that acceptable?
Yeah. Everybody always wants us to do something for them. First of all, however you document is fine. I had a discussion with one of our new committee members who's super savvy on all this tech stuff, and I'm an absolute dinosaur. He likes to text his colleagues about treatment plans, but he can't print it. I said, useless. If you can print it and put it into the medical record, whether it's the cocktail napkin, a little sticky that you tape on, anything is fine. And so as long as you, and I don't know enough to know if you can print those notes. I mean, I don't have a personal cell phone. I just don't like any of that. But if you can print up your notes, if you can send it to a computer or whatever you would do and print that up, then that is absolutely fine. And if it doesn't automatically date and time it, that would be a good idea, but then at least just say into it or write into it what the date is. But no, that's a great idea. If this technology works and you can print it and put it in any kind of form and then scan it into anything like that, is brilliant. And I'll write down.
Hi. David Middleman from Park Ridge, Illinois. A pediatrician tells a patient's parents to refer a patient to me, and they call my office and they have an insurance I don't want to accept, like public aid. What's my obligation?
Okay, so I was writing down the iPhone app. What was the beginning? I heard that you don't want to accept them.
Right, the pediatrician told the patient to call me.
Okay, so you may choose to see whomever you want. You may choose to see or not see anybody. And except if you're in the emergency room during the medical screening exam, anywhere else, it's absolutely fine to have financial protocols. So if somebody calls and they're not a patient, and it's best to have your staff start with, here are the plans we take. Are you on one of them? No. Well, then we're not available. Okay. You'd want to let your pediatrician colleague know, I'm not taking that kind of patient anymore, I don't take that plan. So in your office, it's absolutely fine. Now, caveats, like this ER referral, that's somebody, especially if your hospital says that's your duty to follow up on that patient until stabilized, I would really be careful about that. And I would treat those patients as if they could pay you twice your normal rate immediately in cash. So ER follow-ups. But anybody else who's referred to you and you have no relationship, you may do all the financial screening you want. It's perfectly fine.
Thank you.
Dot Moore from Delaware. We have a similar problem to the other physician with on-call responsibilities. I'm a pediatric ophthalmologist, but when I'm called, I'm covering everything in the northern half of my state. So it's all the adult stuff. Frequently, the smaller institutions downstate do not have an ophthalmologist on coverage full-time. So frequently, we'll get calls sent into our major medical center. They may talk to the ER doctor, they may not, but we have this access center where it's just a clerk who then is told to call us. What kind of response? I mean, I've tried to refuse these. I've tried a bunch of stuff. The guys on my service who are in charge of our call system say just refer it up to Wills if you don't feel comfortable with it. But frequently I get these calls from ER docs, and I tell them very clearly up front, I'm not covering you. I've even gotten calls from out of state because we're the big gorilla and we're just getting all the calls because they don't have someone available to them, which puts me in a real bind.
I'm going to let Ann answer that because I've got to go, but I just think it's important that everyone knows this is a huge, huge problem. This ER coverage is a huge, huge problem everywhere. I mean, even in Newport News, USA, where I am, not exactly the academic center, we have the exact same problem where the one hospital gets all of the stuff from everyone else. So, and it's been, I think at every single Omic talk that I've given, that question has been asked.
So first I want to please help me thank Denise for her outstanding job.
Thank you to Ann. Thank you to all of you for being here.
So I'm told that I'm supposed to wrap it up, so we will take the 3 standing people, and then they can fit this room for our party, but I will just hang around and hand me or someone at the outside desk your green sheet. So you're bringing up a really important question, which is we've talked a lot about when are you required to respond, but what happens if you know, and it's not just that you're tired and you don't want to do it, but you know, oh, I thought that was somebody behind me, it's me. You know you can't handle the patient. This is really tricky. If the emergency room physician asks you to come in, go in. Do not argue. It's not worth it because they're going to have to write your name down as refusing to come in, and then you're in for fines and everything. So go in, and whoever the person assigned to ask you to come in, get there, evaluate the patient, and then say, the patient has X, the patient has an open globe, and I am not competent to treat this. You tell the ER physician, you tell the patient, and you tell the ER physician, you need to find somebody. They will try and get you to find somebody to help them. You may do that, but you're not required to do that. So if you exceed your competency after evaluating the patient, you are still expected to stabilize that patient to the best of your knowledge and ability and to explain what further care needs to be done, and you want to document all that. And I got a little distracted during the question part, but anyone who is designated as the person to contact you, you must respond to. And if you don't like that system, and from what you're describing it sounds horrible, then you have to keep following up and nag them with letters. But do go, if asked to go in. Now, if you're not asked, and they explain what the patient has, and you know that you're not going to be able to handle it, let's say it's really clear this needs a retina specialist, you can say, I'm happy to come in, but I can tell from what you're describing that this patient needs a retina specialist, and here's why. And if the ER physician is fine with that, then you don't have to go in. But you would document that you offered to go in, you recommended a retinal specialist, and the ER physician agreed to contact the retinal specialist.
Would that also apply if this is they're calling us from another county, another hospital that we've normally done cover for, they want to know if we will accept this as a transfer?
Well, again, my recommendation is you should not be the one they're calling for that. So some central person in the hospital should be the one who sees what patients are there, knows the census, knows what equipment specialists are available. So then you would just know on your on-call days who's that person and say, I'm not the person you need to speak to. The person who handles that question for our hospital is this person. And you give them the number and you document that's what you told them. So if they're asking you to do that, I don't think it's appropriate, and I would have written conversations explaining why it's not a good idea for you to be doing that. So you need to clarify something with your system. Yes, sir.
Yes, Niels Mungan from Jackson. My question is about discharging patients who are, continual no-shows. I've been told, though, that if they have an ongoing medical issue, let's say, for example, that it's not urgent. Of course, we know that if it's urgent, we have to continue with them. But let's say it's important medical problem, but not urgent.
Thank you
that
so much.
I've been told that until they find another physician, I'm still responsible for the patient, even if I've sent them these nice or not so nice letters saying, you are hereby discharged.
Right. Thank you so much for raising that, and I'm really remiss that I didn't mention the couple of things you have to do before you discharge a patient. You may not discharge a patient who's in an acute situation, but everybody has eye diseases that go on for a very long time. So once the patient is no longer acute in your judgment, then you give them the 30-day notice, and when the 30 days is up, it's up. And so let's say that the patient is on drops and you continue to prescribe the drops for 30 days, or they need to come in during that 30 days. But every time you do something for them, you remind them, remember, your 30 days is up on April 1st. And after that, we are not available. So no, you are not required to continue to treat until just resolve acute conditions. And if in doubt, if you're not sure if it's acute or, again, that's not... it's a medical judgment, and so I would document why you think the patient is stabilized enough to be able to go see someone else.
Do we have a duty to find them another physician?
No, thank you for raising that. So it's nice. So if the patient has any kind of insurance, all you do is say, check with your insurance company. That's all you say, because they're going to want somebody on their panel. If you know of other people, it's nice to give that. Or you can simply say, use the Find an IMD on the American Academy website. So no, you are not required to. If you know of people in the same specialty, or you know the nearest other pediatric ophthalmologist, they're being subtle now, then you can give that name, and it's helpful. Because remember, what's your goal? You want them to leave. You want them to leave.
And
so
there's two caveats that go with that, though. Number one, check your provider agreement contract, because often they specify, and also your state law. In Pennsylvania, we have to give 60 days.
Oh, thank you. I didn't know that. Yeah. It's very rare to have a time stipulated. The AMA guidelines, the AAO guidelines, every guideline I've ever seen is 30 days. But thank you for that